This is the Musculoskeletal Voice-Over PowerPoint. It is the last unit in your MedSurg 1 nursing course. So we are halfway there, folks. So in this PowerPoint, we will discuss some anatomy and physiology of the musculoskeletal system, although you've already learned about that in A&P, but we should go over it just to refresh your memory. And then also we'll be talking about the health history and physical assessment of the musculoskeletal system. Okay, first off, I want to say that anatomy and physiology is not one of your objectives that you need to learn, but just so you know some of the anatomy when we get to talking about the disorders, so you can understand how that works. So a lot of this will just be a quick review for you. So first off, the bone. The function is to support the body, protect the internal organs like the skull protects the brain, the ribs protect the lungs and the heart. Also for voluntary movement, blood cell production, and mineral storage. So each long bone consists of the epiphysis, which is the end of the bone, the widened area, the diaphysis, which is the long part of the bone, and the metaphysis, which is the part that starts widening before we get to the end, or the epiphysis. So the epiphysis is found at the end of each long bone. It's composed primarily of cancellous bone. The wide epiphysis allows for greater weight distribution and provides stability for the joint. The epiphysis is also the location of muscle attachment. The diaphysis is the main shaft of the bone, the middle part, the long part. It provides structural support and is composed of compact bone. The tubular structure of the diaphysis allows it to more easily withstand bending and twisting forces. And then the metaphysis is the flared area between the epiphysis and the diaphysis. Like the epiphysis, it's composed of cancellous bone also. Now, the epiphyseal plate, or the growth zone, or sometimes you hear that referred to the growth plate, is the area between the epiphysis and the metaphysis, and it actively produces bone to allow longitudinal growth in children. So if there is injury to this epiphyseal plate in a growing child, it can lead to a shorter extremity that can cause functional problems. In the adult, the metaphysis and epiphysis become joined as this plate hardens to mature bone. The periosteum is the outer layer of the bone. It's composed of fibrous connective tissue that covers the bone. Tiny blood vessels penetrate the periosteum, and that provides nutrition to underlying bone. The inner layer of the periosteum is attached to the bone by bundles of collagen. The medullary or marrow cavity is in the center of the diaphysis, that middle long part of the bone, and it contains either red or yellow bone marrow. Now, in the growing child, red bone marrow is actively involved in blood cell production, which is hematopoiesis. And in the adult, the medullary cavity of long bones contains yellow bone marrow, which is mainly adipose tissue. Yellow marrow will only be involved in hematopoiesis in times of great blood cell need. In adults, red marrow is mainly found in the flat bones, such as the pelvis, skull, sternum, cranium, ribs, vertebrae, and scapula, and in the cancellous or spongy material that's located at the epiphyseal ends. like in the femur and humerus. So here's a video if you would like to watch it. It's about 14 minutes in length, and it'll go over the microscopic structure of the bone. And also in the following slides, I will cover the main points that you need to know for when we get into disorders of the musculoskeletal system. Cancellous bone lacks the organized structure of cortical bone. So cortical bone is the compact and dense part of the bone, and then cancellous is the spongy part. If you look in your book, or you could look back on a number 3 slide, but in your book on page 1490, you can see that long bone and see at the top of it is the spongy bone, that porous looking part of the bone. The 3 types of bone cells are osteoblasts, osteocytes, and osteoclasts. Osteoblasts synthesize organic bone matrix or collagen, and these are the basic bone forming cells. Osteocytes are the mature bone cells. And then osteoclasts participate in bone remodeling by assisting in the breakdown of bone tissue. So bone remodeling is the removal of old bone by osteoclasts, and that's considered resorption, and the deposit of new bone by osteoblasts, and that's also called ossification. The inner layer of the bone is composed primarily of osteoblasts with a few osteoclasts. Now, I wasn't going to cover this until we get to fractures, but while we're talking about osteoblasts, osteocytes, and osteoclasts, you might as well turn to, in your book, about how fractures heal on page 1513, or it is figure 63-8. And I'll cover this again later, but you can see it has an A, B, C, and D, and E picture. And this is how bones heal. So A, we have the bleeding at the fractured ends of the bone, and there's hematoma formation. And then B, organization of hematoma into the fibrous network. C, invasion of osteoblasts there. You can see the bone is starting to heal. And there's lengthening of collagen strands and deposits of calcium forming. And D is the callus formation, or new bone that's being built up as osteoclasts destroy dead bone. So callus formation is basically new bone cells regenerating. Remodeling is accomplished as excess callus is resorbed and trabecular bone is laid down. So basically, if you have a doctor looking at an x-ray, let's say, at a fracture that's healing, and he says there is callus formation, what does that mean? That means there is healing occurring. So basically osteoblasts are synthesizing there to form that callus formation. So now we're reviewing the different bone types. And those are long bones, short bones, flat, and irregular. Let me find the page we were on. We were back on page 1491. But the reason I'm reminding you of these different types of bones is because each one with a fracture may produce different abnormalities or complications, depending on what type of bone it is. So your long bones have the central shaft or the diaphysis. So these kind of bones are like the femur, the humerus, and the tibia. Short bones are cancellous bone. And remember that cancellous bone is spongy bone. And it's covered by a thin layer of compact bone. So those are like the carpals in the hand and the tarsals in the foot. Your flat bones have 2 layers of compact bone separated by a layer of cancellous bone. And examples of these are the ribs, the skull, scapula, and sternum. And the spaces in the cancellous bone, don't forget, do contain bone marrow. Irregular bones, they appear in a variety of different shapes. And these are like the sacrum, the mandible of the jaw, and ear ossicles. So now let's review the joints. A joint or an articulation is a place where the ends of 2 bones are in proximity and move in relation to each other. So joints are classified by the degree of movement that they allow. The picture on this slide here, it might not be very clear. The same picture is in your book on page 1492. So it talks about the different joints, and basically they're just named because of how they move. Also, on page 1491 of your book, there's another picture of joints in relation to the skeleton. So there are different classifications of joints, like immovable joints and slightly movable joints, and diarthrodial, which are freely movable joints. And the most common joint is the diarthrodial, or the synovial type of joint. Each joint is lined by a synovial membrane, which secretes a thick synovial fluid to lubricate the joint. That also reduces friction and allows for opposing surfaces to slide smoothly over each other. We'll learn with different disorders of the musculoskeletal system how sometimes the synovial joint can become inflamed or have too much synovial fluid. Probably talk about different diagnostic tests where they remove synovial joint to examine it. And then we need to talk about cartilage. There's 3 types of cartilage tissue. They are hyaline, elastic, and fibrous. Hyaline cartilage is the most common, and it contains a moderate amount of collagen fibers. It's found in the trachea, bronchi, nose, epiphyseal plate, remember that's the growth plate, and articular surfaces of bones. Then there's elastic cartilage, and that contains both collagen and elastic fibers. It's more flexible than the hyaline cartilage, and that is found in the ear, the epiglottis, and the larynx. And then there is fibrous cartilage. It consists mostly of collagen fibers and is a tough tissue. This often functions as a shock absorber, and it's found between the vertebral discs in our spine, and also forms a protective cushion between the bones, like of the pelvic girdle, the knee, and shoulders. Cartilage and synovial joints serve several functions. It's to support for soft tissues, provides joint movement, and it protects underlying tissue. The cartilage in the epiphyseal plate is also involved in the growth of long bones before physical maturity is reached, like in childhood. Because the articular cartilage is considered to be avascular or without vessels, it must receive nourishment by the diffusion of material from the synovial fluid. The lack of a direct blood supply contributes to the slow metabolism of cartilage cells. This explains why healing and repair of cartilage tissue occurs slowly. Okay, and then to review the muscles, the three different types are cardiac, skeletal, and smooth muscles. Cardiac, of course, is in the heart. This is an involuntary muscle. It is striated tissue. Skeletal attaches to the bones. And this is voluntary muscle. We can purposely make these muscles move. And then we have smooth muscles that are found in the walls of hollow organs, like the GI tract, the urinary tract, different areas like that. So when we discuss how the muscles work, skeletal muscle contractions do allow posture maintenance and body movement and facial expressions. When we talk about isometric contractions, this increases the tension within a muscle, but it does not produce movement. So repeated isometric contractions make muscles grow larger and stronger, like when we exercise or lift weights, our muscles get bigger. Now, isotonic contractions shorten a muscle to produce movement. Most contractions are a combination of tension of isometric and isotonic, or shortening. Muscle atrophy means wasting away or a decrease in size, occurs in the absence of a contraction. And this results from immobility, whereas increased muscular activity leads, the opposite is increased muscular activity leads to hypertrophy, or increase in size. An example of muscular atrophy, this is kind of weird, but I had a cat once that broke her leg. She had to have a cast on that leg. I think they may have gotten the cast too tight, but anyway, she did not use those muscles. And I do believe probably the vascular structures were damaged. When they took the cast off, it was very small. Maybe some of you have had a cast before, and when that cast was removed, you just had some muscle atrophy. There was definitely a decrease in size from your other arm that did not have a cast. Now, the neuromuscular junction, skeletal muscle fibers require a nerve impulse to contract. Acetylcholine is released from the presynaptic neuron and diffuses across the neuromuscular junction to bind with receptors on the motor end plate of the muscle. In response to the stimulation, the reticulum releases calcium ions into the cytoplasm. The presence of calcium triggers the contraction of the myofibrils. So when calcium is low, tetany, or involuntary contractions of skeletal muscle, can occur. Do you remember when we talked about fluid and electrolytes? When we had hypocalcemia, there was tetany, or that abnormal movement of the arm. that involuntary drawing up of the muscles. The energy source in the muscles, the direct energy source is ATP. Next, we have some other structures of the musculoskeletal system, such as the ligaments and tendons. They're both composed of dense fibrous connective tissue. They contain bundles of closely packed collagen fibers. Tendons attach to muscles as an extension of the muscle sheath that adheres to the periosteum. Remember, that's the layer over the bone. Ligaments connect bones to bones, like the tibia to the femur at the knee joint. These have a higher elastic content. The tendons, they have a higher elastic content than tendons. Provide stability while permitting controlled movement at the joint. Ligaments and tendons have a relatively poor blood supply, so this makes them longer to heal. The fascia refers to the layers of connective tissue with intermeshed fibers that can withstand limited stretching. If you look on page 1493 of your book, or figure 62.5, there's a structure of a muscle there, and you can see that the fascia just is that covering over the muscle. There's different types of fascia. The superficial fascia that lies right under the skin, and deep fascia is a dense fibrous tissue that surrounds the muscle, the bundle nerves, and the blood vessels. It also encloses individual muscles, allowing them to act independently and to glide over each other during contraction. Fascia also provides strength to muscle tissues. You might hear of something later on called plantar fasciitis. So that would be just inflammation of the fascia. Basically, that's what leads to heel spurs. That pain in the morning when you get up, first thing is usually when it hurts the most. Some of you may have had plantar fasciitis. And the next thing would be the bursa, and these are small sacs of connective tissue lined with synovial membrane, and they contain viscous synovial fluid. They're typically located at bony prominences or joints, and they relieve pressure and decrease friction between the moving parts, like the bursa between the patella and the skin, the elbow and of the skin, between the head of the humerus and the acromion process. Sometimes these bursa sacs become inflamed, and we'll talk about that with some disorders. And sometimes even with diagnostic tests, they will be looking into these bursa sacs. Okay, gerontological considerations on the musculoskeletal system. You need to understand why, what happens, what is normal with aging. There is a table on page 1494 in your book. It's table 62.1. So basically the bone remodeling process is altered in the aging adult. We have increased bone resorption and decreased bone formation. So this causes a loss in bone density, and it could develop into osteopenia and osteoporosis. Muscle mass and strength do decrease with age, Almost 30% of muscle mass is lost by age 70. A loss of motor neurons can cause additional problems also with skeletal muscle movement. Tendons and ligaments also become less flexible, and movement becomes more rigid. So many of the functional problems of the elderly are related to changes in the musculoskeletal system, as you've seen at clinicals. Some changes do begin in early adulthood, and obvious signs of musculoskeletal impairment may not appear until later adult years. So this may affect their self-care tasks, ability to take care of themselves, doing their ADLs. So this may range from mild discomfort and decreased ability to perform ADLs all the way to severe and chronic pain and immobility. Risk of falls also increases in the older adult because of a loss of strength. Aging can bring changes to the patient's balance, and the term we would use for this would be proprioception, and that basically means the awareness of self in relationship to the environment. This may be altered. Okay, now we get to our first objective, and that is discuss the significance of the health history and physical assessment of the musculoskeletal system. We need to obtain subjective data such as health management, nutrition, elimination, and activity. So we want to know specifically about certain illnesses. Some illnesses can cause problems with the musculoskeletal system. Some of these would include like tuberculosis, poliomyelitis, diabetes, parathyroid problems, hemophilia, rickets, soft tissue infection, any neuromuscular disabilities. Any past trauma to the musculoskeletal system is a common reason for seeking medical evaluation. So our questions need to focus on symptoms of arthritic and connective tissue diseases. So you may want to ask them specifically about any signs and symptoms that could be from gout or psoriatic arthritis, maybe lupus, osteomalacia, osteomyelitis, any fungal infections, because this can affect the bones and joints also. So some other infections you would want to ask them about would be like infections of the ears, tonsils, teeth, sinuses, lungs. These infections can enter the bones and result in osteomyelitis, an infection in the bone, or even joint destruction. Question women about their menstrual history. We want to know about any premenopausal amenorrhea, and that means an absence of the menstrual cycle. And this can contribute to the development of osteoporosis. And menopausal or postmenopausal women can also be at greater risk of developing these. So their functional health patterns, we want to know about their sleep and rest. Does anything affect their comfort, their ability to sleep with their musculoskeletal issues? Anything cognitively, and their self-perception. Self-perception, they could be depressed because they can't, they're not as mobile as they used to be. And maybe this produces some anxiety also. So, of course, some common signs and symptoms of musculoskeletal impairment would be pain, weakness, maybe some deformities, limitation of movement, stiffness, joint crepitation. Crepitation is just when you feel over the joint and you feel this creaking movement in the joint. Okay, continuing on with the health history and assessment, we have objectives 2 and 3, which is explain the appropriate techniques used in the physical assessment of the musculoskeletal system, and we want to evaluate the important assessment findings in a client with these health problems. So continue on with some of these health history questions that you might want to ask your people. You've all done a health history, but specifically with the musculoskeletal system, you want to know what are their usual daily activities, and do they have any difficulties performing these? And what do they do if they experience difficulty? You want to know the level of their performance of ADLs, like can they prepare meals for themselves? Can they do basic hygiene? Can they write with a utensil, use the phone, and house cleaning? Do they usually have to lift heavy objects with maybe their work, or do they have repetitive motion or joint stress? Ask them about any specialized equipment they may use at work to help them from injury. Ask them about any drugs that they take, including herbal products to manage their problems. And nutritional, we want to know what their daily intake of food and snacks are. Do they have difficulty in preparing food? What kind of supplements do they take? Especially about calcium and vitamin D. We want to find out about their weight. Any recent weight loss or gain could be a sign and symptom of a musculoskeletal issue. Their elimination patterns. Are they able to get to the bathroom in time in order to maintain continence? Do they have any assistive devices, or do they need some, like a toilet riser? Do they have constipation? They could have this because of decreased mobility, or drugs, especially if they're taking narcotic medications. Their activities, we want to know if they exercise, and do they experience musculoskeletal systems before, during, or after exercising. Not just with exercising, we want to know if they're hurting at rest, or if they specifically hurt after activity. And this can really help you with deciding on which disorder. Like rheumatoid arthritis is usually mostly pain with rest, where osteoarthritis is mostly pain with activities. We also want to know if they have any prosthetic devices or orthotic devices. So the difference with those, prosthetic device would be a fake body part, and orthotic is a device that aids in a body part. Like, for instance, I have an orthotic device I put in my shoes to treat plantar fasciitis. Some more subjective data. We've already talked about what kind of past medical problems. We want to include past surgeries, certain illnesses. We talked about that. Especially ask about family health history. A lot of these disorders can be genetic. Additionally, past or developing musculoskeletal problems can affect their overall health. So some of these might be their role relationship patterns. You know, how do they have a caretaker, or do they have to take care of people? Their sexuality is another part of this. Do they have pain that is affecting this area? Their coping and stress tolerance also. And then their value and belief pattern. Maybe they have some beliefs that would prevent them from seeking treatment or taking certain medications. You want to get a detailed list of their medications. Inquire especially about skeletal muscle relaxants like Flexeril, opioids that they take, some non-steroidal anti-inflammatory drugs such as ibuprofen or Celebrex, any systemic and topical steroids that they may use, any anti-seizure drugs, phenothiazides, corticosteroids, especially corticosteroids, as steroids can place them at increased risk of developing osteoporosis. Any potassium depleting diuretics, and that would affect the muscles. Remember, it does affect the heart muscle, so of course it would affect other muscles as well. Any vitamin D and calcium supplements. Okay, with our objective data, a musculoskeletal assessment can focus on one specific body part. Could be done as a part of a general examination, or it could be done as an examination on its own. The nurse, you should listen to what the patient is telling you and use that as a guide in selecting the components of your history and physical examination. Range of motion is most accurately assessed with a tool called a goniometer. This measures the angles of the joints. There is a picture of it in your book, figure 62.7. I have one I'm going to bring to class so you guys can look at that. Really, in all my years of nursing, I've never used one, but I suppose it just depends on what area of nursing you work in. Therapists use these quite a bit to measure if their joints are moving better, let's say after a knee surgery. You know, what is the degree of motion, and it can assess if it's improving. Specific degrees of range of motion of all joints are not usually measured. They don't go through and use that goniometer for every single one, usually just the problem areas. A less exact but valuable assessment method is to compare the range of motion of one extremity with the range of motion on the opposite side. So, of course, we want to be doing bilateral assessments to compare. So our musculoskeletal assessment includes inspection, palpation, and motion. So first we'll look at inspection. We want to use a systematic inspection, starting at the head and neck and proceeding to the upper extremities, the lower extremities, the trunk. We want to look at the skin for general color, any scars, any other overt signs of previous injury or surgeries. Look at their general body build, their muscle configuration, and the symmetry of their joints. Are they equal on both sides? Observe for any swelling, deformity, nodules, or masses, as these could be indications of some type of disorders. And any discrepancies in limb length or muscle size. Use the patient's opposite body part for comparison when an abnormality is suspected. So let's say you notice somebody that has a gait disturbance. Probably one of the first things you would want to do is measure for any discrepancies in length or muscle mass size. Okay, the next thing is palpation. We want to carefully palpate any area that has aroused concern. Now don't forget that they're in pain, so be careful. So anything that they have complained of or that appears abnormal on inspection. Just with inspection, palpation usually proceeds from head to toe to examine the neck, shoulders, elbows, wrists, hands, back, hips, knees, ankles, and feet. Both superficial and deep palpation are usually performed consecutively, which means like side to side. You want to make sure to warm your hands to prevent muscle spasm, which can interfere with your assessment. Palpate both muscles and joints to allow for evaluation of skin temperature, any tenderness, any swelling, and crepitation. And then we want to establish the relationship of adjacent structures and evaluate the general contour or abnormal prominences and local landmarks. As most of you know, I have rheumatoid arthritis. When I go to my rheumatologist, she goes through every single one of my joints in my body to assess them. She's very thorough. So everything from my head to toes, each joint at my fingers, thumbs, elbows, shoulders, on down. And now assessing motion, we want to assess the active and passive range of motion. So carefully assess those. We want to move the joint at the full potential of it. Of course, if they complain of pain or there's resistance, you need to stop manipulating that joint. I mentioned earlier the goniometer, and this will measure their joint movement. Also, there's a muscle strength test. Picture of that is on table 62-4 or page 1498 of your book. And this just grades what their muscle strength is. So a normal muscle strength is a 5 bilaterally, and that just means with full resistance to opposition. The patient applies resistance to the force that the examiner is exerting. So, like for example, try to pull the bent arm down while the patient attempts to raise it, just to see how much strength is there. You compare the muscle strength with the strength of the opposite extremity. So note any subtle variations in muscle strength when comparing the patient's dominant side with the non-dominant side. Variations in strength also exist when comparing individuals. What they mean by that is not everybody is going to have the strength of, let's say, a healthy male compared to an elderly female. Also, we want to take measurement when there's length discrepancies or other problems noted. We want to obtain limb length and the circumference of muscle mass measurements. So when you notice there's a gait disturbance, probably one of the first things you want to do is measure the leg length to see if there's any discrepancies there. You would measure the affected limb between the anterior superior iliac crest and the bottom of the medial malleolus, so from the hip to the heel, and then compare it with the opposite side. When you're measuring these areas, also you want to make sure that you give an exact location of where you're measuring. If you're measuring the circumference of a muscle, you want to measure at the widest part of the muscle. And you could put in your documentation, like for example, you measured the quadricep muscle 15 centimeters above the patella. So that just makes sure the next person that's assessing it is assessing it at the exact same place. So here's that muscle strength scale that I was talking about. It's also on page 1498 of your book. You probably want to review the terms that we used when we learned about range of motion back in foundations. Some of the main ones are abduction. Remember, that is away from the body. Adduction is moving it towards the body. Flexion is the bending of the joint, and extension is straightening the joint. This little picture that I added on this slide here is kind of how measurements are done with a goniometer, the different degrees that we can flex and extend a part of the body. There is also a straight leg test that can be performed on a person with sciatic nerve pain or leg pain, and they just lay supine, and you passively raise their legs 60 degrees or less. It is positive if they complain of pain along the sciatic nerve. So that again is called the straight leg raising test. Other terms that you should probably review are on page 1498. It's table 62.3. I just added the terms that are most frequently used here. I've already discussed most of these with the focused assessment, your subjective information. Your objective information could include diagnostic tests also, like x-rays, bone scans, and blood tests like ESR rate, which is a SED rate. And then we talked about our physical assessment with inspection and palpation and motion. So of course, if we're going to be doing an assessment, we need to know what the normals are. So our spine does have normal spinal curvatures. I don't know if you can see that picture very well there. Also, we do not have muscle atrophy or wasting away, or asymmetry, which means unequal sides. Normally, we do not have any joint swelling, any deformities, or crepitation. And then also, the rest of the normal assessments include no tenderness on palpation of the spine joints or the muscles. And people should be able to have a full range of motion on all joints without pain or laxity. And laxity just means looseness. Our muscle strength normally is 5. Here's an overview of some terms that you should probably go over. There's a long list of them on table 62.6, which would be page 1500 of your book. I just listed the most common ones that I've heard over time on this slide here. Achilles tendonitis is that area behind your ankle. It just feels like a pulling or tightness, and sometimes joggers may get this. It can also progress to pain at rest. Some disorders also cause this, like rheumatoid arthritis. Ataxic gait is another one I listed. It's a staggering, uncoordinated gait, often with a sway. So some neurological disorders can cause this kind of gait. And then atrophy, we've mentioned that several times, is just the wasting away of the muscle. Ganglion cyst is another one. It's a small fluid-filled bump or mass over a tendon sheath or joint, usually on the dorsal surface of a wrist or foot. And that's just inflammation of tissues around a joint. It can increase in size or it could even disappear. I do believe a layman's term for this is I can't remember for sure, but like a Bible cyst, because supposedly if you hit it with a Bible, it will go away. But anyway, that's just a crazy saying they say about that. Some disorders may cause these ganglion cysts. Another one is kyphosis. And that's just an exaggerated thoracic curvature. Some possible causes of this are poor posture, tuberculosis, some types of arthritis, osteoporosis, and some growth disturbances. The next one is lordosis, and that's asymmetric scapula. You know, the scapula along your shoulder blades, they are not equal in the shoulders, and there's an exaggerated lumbar curvature. So some things that cause this would be like spinal deformities, muscular dystrophy, maybe obesity, flexion contractures of the hip, and some congenital disorders also can cause that. The next one is myalgia, and that's just general muscle tenderness and pain. Maybe you've heard of fibromyalgia. That would just be pain in some muscle areas. So some rheumatoid syndromes cause this, and then they list fibromyalgia. Overuse, injury, or strain can also cause this. The next one is plantar fasciitis, a burning sharp pain on the sole of the foot. It's worse in the morning. So there are some things that you can do to treat that. Like I told you, I have orthotic devices. And I do believe people with mainly a flatter foot, this causes that. So the orthotic device just kind of helps you relearn how to walk correctly with the correct arch. And these can lead to your heel spurs over time. Scoliosis is another one. There is a picture of scoliosis in your book on page 1498. And in your book, it does discuss how to assess for that. You can read that on your own. Basically, it's an S-shaped curvature of the thoracic and lumbar spine. So now we're at Objective 4. Explore diagnostic tests used for assessment of musculoskeletal function and the nursing responsibilities of each. This is in your book on table 62-7. They list some. So your standard X-ray. The X-ray is the most common diagnostic study used to assess musculoskeletal problems, and it's used to monitor the effectiveness of treatment. Bones are denser than other tissues, and X-rays do not penetrate them. So the dense areas show as white on a standard X-ray. X-rays can show bone deformities, joint congruity, bone density, and calcification in soft tissue. It would be used in fracture diagnoses, and they're useful in the evaluation of genetic, developmental, or infectious, or inflammatory, or neoplastic with cancers, metabolic, and some degenerative disorders. Skipping down to the bottom of this slide, an endoscopy or an arthroscopy. This is a small fiber optic tube called an arthroscope is used to directly examine the interior of a joint cavity. So after anesthesia has been administered, a large bore needle is inserted into the joint, and the joint is distended with fluid or air. You can look at figure 62-9 for this, which I don't know what page that's on. Page 1499 in the new book is a picture of them performing an arthroscopy. And actually in that picture you can notice the monitor in the background, so they can visualize the joint cavity. They can take photographs or videotapes through the scope. A biopsy may be taken of the synovium or even the cartilage. Torn tissue can be repaired through this surgery, and this is helpful because it eliminates the need for a larger incision, which decreases recovery time when you don't have that large open procedure. An arthrocentesis or joint aspiration is usually performed for synovial fluid analysis. So it may be done to remove fluid from joints to relieve pain. The skin is cleaned, and then a local anesthetic is given. After an 18 gauge or larger needle is inserted into the joint, the fluid is then withdrawn and then put into a sterile container, which is sent to the lab. Patients with inflammatory joint conditions like rheumatoid arthritis, osteoarthritis can be treated according to the results of this. Okay, I didn't finish what I was going to say on my last slide, so this blank one, we're just going to talk about the joint fluid that was aspirated, the synovial fluid. So when they draw that fluid out, they're going to be looking for the volume, the color, viscosity, which means the thickness of it, and the mucin clot formation. So normal synovial fluid is transparent and colorless or straw-colored. It should be scant in amount and of low viscosity, which means not as thick. If it's an infected joint, it may be purulent and thicker gray and thin. In gout, which is an accumulation of uric acid, the fluid might look whitish yellow. Blood might be aspirated if there's hemarthrosis due to injury or a bleeding disorder. The mucin clot test usually indicates the character of the protein portion of the fluid. When there is inflammation, the clot fragments easily, and the fluid is also examined for floating fat globules, which may indicate some bone injury. In septic arthritis, protein content is elevated and glucose is considerably decreased. And then, like I said, presence of uric acid in that would suggest a diagnosis of gout. Okay, and I did it again. I need to finish talking about a discogram, a CT scan, a myelogram with or without a CT, and an MRI. So a discogram is an X-ray of cervical or lumbar intervertebral disc. It's done after injection of contrast media, and this just permits visualization of the intervertebral disc abnormalities. So we want to make sure they are not allergic to the contrast medium before that is done. And of course we want to explain the procedure. Now, a CT scan is an X-ray beam that's used with a computer, and that provides a three-dimensional picture. So this is mostly used to identify soft tissue abnormalities and maybe bony abnormalities and some musculoskeletal trauma. This would be used if you want to get a better picture of, X-ray would show more bone. If you're looking more at soft tissue, this would be a better test. We need to let the patient know that this is a painless procedure. They have to stay still during the procedure. And again, if the contrast medium is being used, we want to make sure they don't have an allergy to shellfish. Okay, and then the other one is a myelogram with or without CT, and that involves injecting a radiographic contrast medium into the sac around the nerve roots. They may do a CT scan after that to show how the bone is affecting the nerve roots. It's a very sensitive test for nerve impingement and can detect very subtle lesions and injuries. So the main risk with this test would be a spinal headache. You should inform the patient that if they do get one, it should resolve in 1 to 2 days with rest and fluids, but they do need to report it to their health care provider. Okay, and now the MRI. This is radio waves and magnetic field that are used to view soft tissue. Again, it's more specific than a CT. It's especially useful in the diagnosis of avascular necrosis, disc disease, tumors, osteomyelitis, some ligament tears, and cartilage tears. So they're placed inside this chamber. They may even be injected with an IV gadol, I don't know how to pronounce that, gadolinium, to enhance visualization of the structures. Some places do have open MRIs that doesn't require a patient to be inside a chamber. So this could be especially helpful for people that are severely claustrophobic. So we want to make sure that there is nothing metal, as this is a magnetic field. So patients with aneurysm clips, any metallic implants, pacemakers, electronic devices, hearing aids, and shrapnel should not have an MRI. Actually, my daughter was accidentally shot in a part of her body before, and she still has some shrapnel inside of her, so she probably would not be eligible for an MRI. Just a little tidbit there for you. So inform the patient that it's painless. The machine does make loud tapping noises intermittently. People can wear earplugs or listen to music while they're in this chamber. Make sure they don't have any metal on or any jewelry, credit cards, anything like that. They have to stay still during the procedure. So that is a little bit difficult for some patients. Some people may need an anti-anxiety agent. So again, an open MRI may be used for obese patients or patients with a large chest and abdominal girth or with severe claustrophobia. I know when my mom has to get an MRI, she's severely claustrophobic. They can't do that here in Scott City for her because she has to have an anesthesiologist administer some pretty heavy-duty anti-anxiety medications. Okay, some more diagnostic studies would be some laboratory studies. Alkaline phosphatase. This enzyme is produced by osteoblasts of bone, and that's needed for mineralization of organic bone matrix. Elevated levels are found in healing fractures, so we do want that with healing fractures. Some bone cancers also will have an elevated level: osteoporosis, osteomalacia, and Paget's disease. Also, serum calcium levels. Bone is the primary organ for calcium storage. Calcium provides bone with rigid structure. Decreased serum levels is found in osteomalacia, renal disease, and hypoparathyroidism. And increased levels are found in hyperparathyroidism and some bone tumors. Serum phosphorus amount is present is indirectly related to calcium metabolism. Remember, calcium and phosphorus kind of work together. So decreased levels are found in osteomalacia. Increased levels are found in chronic kidney disease, healing fractures, osteomyelitic metastatic tumors or cancer. Another one is the rheumatoid factor, and this just assesses for a presence of an autoantibody, which is the rheumatoid factor in the blood. The factor is not specific for rheumatoid arthritis and is seen in other connective tissue diseases as well as in a small percentage of normal population. So just because somebody has a positive rheumatoid factor, it's pretty indicative that they have rheumatoid arthritis, but not necessarily. And just because somebody does not test positive for rheumatoid factor doesn't mean they don't have rheumatoid arthritis either. Okay, the next one is erythrocyte sedimentation rate, or ESR. We call this the SED rate. It's a nonspecific index of inflammation. So it's just measuring inflammation in the body. Measures rapidity of which red blood cells settle from unclotted blood in 1 hour. Results are influenced by physiologic factors as well as diseases. So like if you have a sprained ankle or something, you might have an increased SED rate. So you can't really differentiate between if it's a disease or just some. But elevated levels are seen with any inflammatory process like rheumatoid arthritis, rheumatic fever, osteomyelitis, and respiratory infections also. Okay, we have some other tests here. Anti-nuclear antibody, ANA. So this assesses for presence of antibodies capable of destroying nucleus of the body's tissue cells. The finding is positive in 95% of patients with lupus. It may also be positive in individuals with systemic sclerosis or scleroderma or rheumatoid arthritis. Sometimes it's found positive in a small percentage of normal population. Anti-DNA antibody detects serum antibodies that react with DNA. So it's the most specific test for lupus. So you can remember that. Okay, the next thing is complement total hemolytic. Complement a normal body protein is essential to both immune and inflammatory reactions. So if there are depletions, this may be found in patients with rheumatoid arthritis or lupus. Uric acid, that's what we are testing for to see if people have gout. Usually somebody with gout has elevated levels, although it's not extremely specific. So uric acid is basically the end product of purine metabolism that's normally excreted in the urine. Then we have C-reactive protein, or CRP. This is used to diagnose inflammatory diseases, infections, and widespread malignancy. This is synthesized by the liver, and it's present in large amounts in serum 18 to 24 hours after the onset of tissue damage. Then we have human leukocyte antigen, HLA-B27. This antigen is often present in autoimmune diseases such as ankylosing spondylitis and rheumatoid arthritis. Now, I know this is a lot of lab tests to take in, but as we get into the disorders, we'll talk about which ones specifically go with each disorders so we can review those also. And I'll try to emphasize the most pertinent ones so you kind of know. I mean, you need to know each one, but which ones specifically you are a must know. Okay, I thought we were finished with those, but we are not. Here's some more. Creatine kinase, or CK. Highest concentration is found in skeletal muscle, but increased levels are found in progressive muscular dystrophy, polymyositis, and traumatic injuries. And we already talked about potassium, increased in muscle trauma, and cardiac dysrhythmias can be caused by hyperkalemia or hypokalemia. Aldolase is useful in monitoring muscular dystrophy. We talked about arthrocentesis, that procedure that they go in to obtain the samples of synovial fluid. An EMG evaluates electrical potential associated with skeletal muscle contractions. So small gauge needles are inserted into certain muscles, and these needle probes are attached to leads that feed information to the EMG machine. Recordings of electrical activity of muscle are traced on an audio transmitter and recording paper. So this is useful in providing information related to lower motor neuron dysfunction and primary muscle disease. So you should inform the patient that the procedure is usually done in an EMG lab while a patient lies supine on a special table. You need to keep the patient awake to cooperate with voluntary movement. Inform the patient that the procedure involves some discomfort with a needle insertion, and the patient needs to avoid stimulants, including caffeine and sedatives, 24 hours before that procedure. In your ATI book, it does talk about EMG. Let me find that here. I do believe some of these are done even without EMG and nerve conduction studies. So there are some that don't involve needles put in, but basically it's just electrical impulses to the nerves to make sure there is proper nerve conduction happening. So here's a video on YouTube if you would like to see a complete musculoskeletal assessment. So that's all for now, folks. I think that's been plenty to go over. The rest of it we'll go over in class, and those will be like soft tissue injury, fractures, amputations, osteoarthritis, rheumatoid arthritis, ankylosing spondylitis, gout, osteoporosis, and osteomyelitis. And basically assessment, interventions, and different things that go along with those disorders. Hope you guys have a good weekend. Sorry the first voice over PowerPoint didn't work. I don't know what happened, but when I switched to Camtasia, it decided to make it a picture instead of an audio. So I hope you're doing okay on your homework. If you have any questions, just let me know. See you on Monday.